Thank you very much for your invitation to speak here in these COVID times. Unfortunately, we're now in the third wave in the Netherlands, and I fear that many of you are also in the third wave. I would like to talk about the dyspneic patient, but I would really like to focus on COVID. I have nothing to disclose. I have no financial ties with any company. So everyone is aware that in these times of COVID, a lot of research is being done. Many investigators are working day and night to get their papers published and to try to curb the course of this pandemic. And you know that when we are confronted with a patient who might have COVID, most hospitals will still perform an X-ray in the emergency department. But everyone here, I think, is perfectly familiar with the fact that actually the X-ray is not very good for finding abnormalities in the thorax. For instance, an infiltrate can be here, there can be fluid here, there might even be an empyema here, and even a very good radiologist cannot help us a lot. So we are switching more and more to use the ultrasound probe at the first confrontation with a patient in the emergency department. As you are all aware, the radiologists have been using CT scanning, and there has been created a grading system for the level of suspicion of the COVID-19 infection on CT. Where there is a CORADS score has been designed mainly by Dutch radiologists, but it's been implemented pretty widely across the world. And the score ranks from CORADS 1 to CORADS 6. But we are using ultrasound probes, and in the beginning of when COVID came to the Netherlands, we were wondering, well, do we really need a CT scan, or can we perform lung ultrasound also? And maybe for not everyone is familiar with this image, even though I think that it has been addressed earlier today. This is taken with a linear probe. There's skin and fat tissue here. There's a pleural line here and two black ribs down here. Actually, for COVID, it doesn't really matter which type of probe you use. This is an image of a normal lung taken with the convex probe. And here you see the pleural line. And so this is a normal image of a lung sliding taken with a convex probe. Sorry, every now and then it goes too fast for me. But up to now, I think most people are used to using a pretty large ultrasound machine. And I think that everyone realized that on the ward, it is actually not very handy to move between the beds with your ultrasound machine. And that's where miniaturization comes along. And I think that it was only a couple of years before the COVID that it was possible to connect an ultrasound probe to a smartphone and then make pretty adequate image, at least for COVID. And there are several industries who are very well able to do this. So nowadays in my department, we run around in our white coats. Within one bag of our coats, we have a probe, either by Lumify or by Butterfly. And in the other one, we have ultrasound gel, so we are always well prepared. One of the advantages in these COVID times is that it's very easy to clean the ultrasound probe with your smartphone, either by just taking an alcohol swab or putting it in a UV machine where it gets radiated. You see the image actually normally is pretty good. This is an example of a pneumothorax where you see the lung point here in the middle of the image. And actually the COVID-19 image of lung ultrasound is more or less comparable to a viral pneumonia. So the pleura normally is rather thickened. There are B lines with a non-homogeneous distribution, or there are confluent B lines, which we call a waterfall phenomenon, or there are subpleural infiltrates. Basically, normally you don't see any pleural fluid or just a very small amount. So this is rather characteristic picture. Here you see a waterfall phenomenon. And here you see a subpleural infiltrate in the top of the image here. So we were looking in the literature to see what was being done, and we found that people were, and especially this came from the ARDS literature, grading the amount of abnormalities we could see with the lung ultrasound scanning. So you can have either discrete B lines, or you can have multifocal B lines, or the waterfall phenomenon. And furthermore, you can have the subpleural consolidations. So in my hospital, we were doing two protocols when COVID hit. So one is that we were performing on every patient who entered the emergency department, CT scan and lung ultrasound scanning. And on the ward, we performed on some patients everyday ultrasound scanning. And the radiologist was not aware of our lung ultrasound results, and we were not aware of the radiologist results. So we scanned 6 areas on each thorax, and we graded every area. So we graded from grade 1 to grade 3, where there was a total loss of lung aeration. Actually, I really like this slide by Smith et al., which shows that the amount of lung aeration decreases, and there you see 0, 1, 2, and 3 in abnormalities. So we graded each lung segment that we were scanning, and we said, okay, how are we going to decide whether this is COVID or not? And this is done in this slide. We thought that we would see a positive lung ultrasound if we saw 3 or more B lines in 2 or more zones unilaterally. Actually, you can read it, it's all on the slide. And on the CT scan, we thought, and we discussed it with the radiologist, that the CORAD score of 5 or 6 was regarded as being positive, and a CORAD score of 1 or 2 was regarded as negative. And actually, we published this in the European Respiratory Open Journal. We had 189 patients who presented in the emergency department who were included in our study. Almost all people consented. So we had 86 positive PCRs and 100 negative PCRs. And I think this is typical of the pandemic that we are in nowadays. And here you see the first results, and actually there was a pretty good correlation between our lung ultrasound results and our CT results. On the slide, it also said final diagnosis, and this was where the PCR actually was negative, but based on all clinical criteria, and their CT scanning was included. We had a panel in the hospital who said, well, even though one PCR is negative, we still give this the diagnosis of COVID-19 pneumonia. Okay, so here you can see our results. Lung ultrasound versus PCR, pretty good sensitivity during a pandemic, and pretty good specificity also. But very important is that the negative likelihood ratio was very good. And this was, I think this is very important for the rest of my talk. So in our view, lung ultrasound and CT, they have comparable diagnostic accuracy for COVID-19 pneumonia. Lung ultrasound can safely exclude clinically relevant COVID-19 pneumonia, and it may help diagnosis in high prevalence situations. And we were not the only ones to discover this. Zilewskiewicz actually did more or less the same study, and they found that in patients with minimal damage, the lung ultrasound score measured in the same way as we did was pretty low, and where the chest severity score was high, the lung ultrasound score was high as well. So what we did, we compared our low lung ultrasound score with our high lung ultrasound score, and we dichotomized at 12, and there it is very clear that the low ultrasound score is giving you a much better prognosis than a high lung ultrasound score. The score ranges from 0 to 36, so 12 is a pretty good score. Also, time to discharge was significantly shorter in the patients who had a low lung ultrasound score. So in our view, and this is what we do daily now with so many patients flooding our emergency department, if we find a low ultrasound score, we send the patient home, wherever that home may be. It may be a castle or a small flat or whatever. If the lung ultrasound score is high, we admit the patient, and very often they end up in the ICU. And if the lung ultrasound score is intermediate, most people are admitted, and then it depends more or less also on the amount of fever and the other results, such as oxygen saturation. And this is now what we do in our daily practice, and it has been demonstrated in many studies that they actually found the same results. So, for instance, this is a study by Julio Cesar, and he also found that the lung ultrasound score predicts outcome in the patients admitted to the emergency department. So this is for the hospital, and only a few days ago this Cochrane library analysis came out, and it said, well, lung ultrasound is sensitive but not specific for the diagnosis of COVID-19, and I think this underlines our results exactly. I think that if there would not be a pandemic, our results would be, especially sensitivity, would be not as good anymore. So it may be good for excluding COVID-19 rather than for differentiating it from other respiratory illnesses. We go one step further. It's not only good for excluding COVID-19, but it's also good for determining prognosis. And in that regard, I think this is a huge improvement for our armamentarium. We've also done what we call, and it's now submitted for publication, where we say, okay, lung ultrasound takes some time. What if we do only 3 lung areas instead of 6 lung areas? So we take 2 anterior areas and 1 posterior area. And we have found that this is excellent for screening. You don't have to do all 6 areas. You only have to do all 6 areas if you want to grade the amount of lung involvement. If you want to rule out the COVID pneumonia, only 3 areas is just enough. And this is done in a few minutes. And we always say that one of the big advantages of lung ultrasound is that you can keep talking to your patient, because when you're listening with your stethoscope, you cannot keep talking to your patient. So actually lung ultrasound does not cost any extra time at all. Okay. So less is more in our view. You don't have to do 12 zones, you can do 6 zones also. So in our view, in the COVID-19 pandemic setting, lung ultrasound is comparable to CT scanning. You don't need to do the CT anymore to grade the diagnosis. It can help in triage. It should be taught as an extension of the physical examination. And it's not only useful, and there we go into the future, at the emergency department, but it may also be very useful in general practice or in nursing homes. And 6 zones can be used for screening. I have not elaborated a lot about the small study that we did, where we went to the patient every day to do a scanning. And here we found that there was not a very good correlation between our lung ultrasound score and the clinical course of the patient. But what we were able to do was to find other abnormalities, for instance, congestion or asthma or whatever. And in that view, lung ultrasound is very useful on the wards also. In my view, a handheld POCUS is here to stay. The image quality is not as good as you get with a large machine, but it's getting better every day and every time I get an update on my phone or on my probe. So we are really convinced that, well, I don't think you should throw the stethoscope out of the window because of fear of hurting people who are walking outside. But I think that lung ultrasound should be part of the physical examination immediately when you're talking to the patient in the emergency department or in the general practice if someone is short of breath. But this is a problem because this would mean that we will have to train many physicians in the future to do this. And training physicians to perform ultrasound is a pretty labor-intensive activity. You need a huge workforce of instructors, and I think we are struggling with that at this moment. When should we train them? I think that we should train young students. In Nijmegen, we've just done a small experiment where we taught second-year bachelor students lung ultrasound, cardiac ultrasound, and abdominal ultrasound. And we did this in a combination with the autopsy chamber. So we would bring them to the autopsy chamber. We would cut through a heart so that it would generate the image that you do see on ultrasound. And then we would let them perform ultrasound on each other. And this led to an incredible increase in their anatomic knowledge and the ultrasound skills. Another way to go would be what Chris is doing with the baby scanner. So maybe in the future it will be possible to have these images analyzed automatically through artificial intelligence. And that would really bring ultrasound to the front in diagnosis, I think. So with that, I would like to end my presentation.